Firstly, let me thank for inviting me to give this lecture. I will be talking on infertility with adenomyosis. How can HIFU help? This is my disclosure. As you all know, I run a ultrasound-based HIFU center at the Makota Medical Center, Malacca in Malaysia. When we look at adenomyosis on ultrasound, there are generally two different types of adenomyosis. Generally, we say something called diffuse adenomyosis and focal adenomyosis or adenomyoma. I think you all know about this book by one of y'all, and this is a good book for adenomyosis, especially for English-speaking people. Okay, when we look at ultrasound diagnosis of adenomyosis, there are basically 8 different features. The first one here that we usually see is called asymmetrical thickening, which means that one part of the uterus is thicker than the other part. Okay, other aspects which are B, C, D, E, F, G, and H. In B, sometimes we see these small cysts. And in C, sometimes we see these little islands, many islands. There's also this fan-like shape structure, which is sometimes very difficult to see. E is actually these echogenic subendometrial lines or buds. We can see this kind of lines or buds. There can be also translesional vascularity. There's some vessels here. And G is irregular junctional zone. And H is interrupted junctional zone. So these are the features that we see on ultrasound diagnosis of adenomyosis. In MRI, I mean, we are all more familiar with MRI. There are basically also diffuse adenomyosis, internal adenomyosis, external adenomyosis, and also adenomyoma. Okay, this is a bit more detailed description. And here you can see that type A, B, C, D, and E, these different types are called internal adenomyosis, which means that the adenomyosis actually starts from the center and then it moves out and involves the myometrium. The other type is called adenomyoma, which is F, G, H, and I. Here, there is a nodule either here inside the myometrium, or it could be a submucosal adenomyoma or even a subserosal adenomyoma. The last type is called the external adenomyosis, and this is type J and type K. Type J is posterior. Usually the adenomyosis comes from the serosa and can involve the rectum. And type K is the anterior, it can involve the bladder. Okay, when we see adenomyosis patients, there are basically 2 types of patients that we see. The first patient are those adenomyosis who do not want to conceive, but just want to keep their uterus. And the second one are those with adenomyosis who want to conceive. In this lecture, I will concentrate on this group of patients, those with adenomyosis who want to conceive. So let's look at what can we do for those who want to conceive. We can do an operation called adenomyomectomy. This is an operation where we cut the uterus, take off the adenomyosis, and then suture the uterus back. This is a very difficult operation to do. And in the second group, we can give the patient GnRH analog or Dynogest, and then see whether they can conceive on their own, or we do IVF, we can do frozen embryo transfer. So I think you all know what is HIFU. HIFU uses focused ultrasound beam to ablate adenomyosis. Okay, what are the advantages of ultrasound-based HIFU? I'm comparing ultrasound-based HIFU, which is this from Chongqing, China, and this is MRI-based HIFU. What is the difference between these two, and what are the advantages and disadvantages? Now, the first advantage is ultrasound-based HIFU, we all know, is real-time ultrasound imaging while performing the HIFU. The second advantage is that we all also know that the transducer used in the ultrasound-based HIFU is bigger and more powerful compared to that in the MRI-based HIFU. The third advantage is that there is better transducer movement during HIFU treatment in the MRI and the ultrasound-based HIFU. The transducer can move in 3 directions, about 12 centimeters on all the directions, whereas the movement in the MRI-based HIFU is much lesser. And of course, because of this, the operation time is also shorter with ultrasound-based HIFU. And lastly, which is probably the most important thing, is because of all these advantages, you have a higher percentage of ablation, which is the NPV, non-perfusion volume, is much better with ultrasound-based HIFU compared to MRI-based HIFU. So what are the benefits of HIFU for adenomyosis patient? The first benefit we all know is non-invasive. There is no incision in the abdomen. The second advantage is when shrinkage of adenomyosis occurs, the uterus will become smaller, and so it will be more amenable to pregnancy. The third advantage is that there's a reduction of symptoms, namely menorrhagia and dysmenorrhea. And the fourth advantage is patient can start conceiving about 4, maybe 6 months after treatment. And the final advantage is patients can even have a normal delivery after the treatment because there is no scar in the uterus. Now, this is my experience. I'm not as experienced as Dr. Hermin. I have only done we started HIFU in July last year, and up to August, I've done about 269. Up to today, we have done about 282 cases. And this is my experience, and I'm going to give some examples of my experience with HIFU in the next few minutes. This is our HIFU center at Makota Medical Center. It's a small room with the J200 machine here. Okay, I will briefly mention the principles of HIFU ablation. What is the difference between ablating fibroids and adenomyosis? Now here we can see a fibroid, and this is the contrast MRI of a fibroid. So when we do ablation for fibroid, there is a capsule, so the ablation is usually can be contained within the capsule. This is another fibroid. But this is not the same with adenomyosis. And adenomyosis, you can see, is all over the place. And it is sometimes difficult to get a very nice ablation as in fibroid as with adenomyosis. As you can see, we have ablated, but it's different because the ablation needs to be very careful so that it doesn't involve the whole area of the adenomyosis. Okay, what is the difference in performing HIFU for patients who want to conceive and not keen to conceive? Now, there are differences because in patients who do not want to conceive, we can do extensive ablation. And this can even include sometimes the endometrial cavity. The success rate of reducing symptoms is higher in this kind of cases. Whereas in patients who want to conceive, the ablation will need to be done more carefully to avoid ablating the endometrium. In this case, the ablation will be limited and the success in reducing symptom will be lesser as less energy will be given to the adenomyotic areas. So what are the challenges in ablating adenomyosis? So the first is not all adenomyosis cases are the same. In some cases, there is a gap between the adenomyosis and the endometrial cavity. In these cases, the chances of reaching the endometrial cavity is lesser. In others, the adenomyosis reach up to the endometrial cavity, breaching the transformation zone. Here, it is very easy to reach the endometrial cavity. The energy must be low and very controlled. Sometimes I wonder whether if the endometrium has already been involved by adenomyosis, whether reaching the endometrium will be beneficial as new endometrium will grow over the ablated endometrium. So here is an example. This is a cavity. In these cases, the chances of reaching the endometrial cavity is lesser. In others, the adenomyosis reach up to the endometrial cavity, breaching the transformation zone. Here, it is very easy to reach the endometrial cavity. The energy must be low and very controlled. Sometimes I wonder whether if the endometrium has already been involved by adenomyosis, whether reaching the endometrium will be beneficial as new endometrium will grow over the ablated endometrium. So here is an example. This is a patient with adenomyosis. And here, after ablation, you can see that I have actually somehow involved the endometrial cavity. I can show you this on this. It is sometimes very difficult to control, and you can affect the endometrial cavity. So this is after 3 months of the ablation, you can see that the ablation is quite affecting around the endometrial cavity. So this case, I actually managed to do a hysteroscopy, and this is the hysteroscopy finding, because after doing the ablation, I did the hysteroscopy to put in a Mirena. So here you can see the hysteroscopy finding. You can see how the endometrium looks like after this ablation of this patient. And you can see that there is some area that the endometrium has actually been involved. And there's some area that it is not involved, it's normal. And so you can see that I am sure that this part that is involved after some time will drop off, and hopefully new endometrium will grow back. And here I'm using the hysteroscopy to push away all this debris, the area probably where the ablation was done. And you can see that I'm sure new endometrium will grow. So this is an example to show how if the endometrium is involved, how the endometrium will look after the ablation. Now, in this lecture, I will look at all the different types of patients who requires HIFU. Now, the first group are the ones who are not keen to get pregnant. The second are the group that are keen to get pregnant. And in the group that is keen to get pregnant, there are patients who already have frozen embryos. And then there are patients who are single, and also there are patients who are keen to try to conceive on their own, spontaneous pregnancy. And then there's another group of patients who is unsure whether they want to get pregnant. So in this lecture, I will concentrate on this group, those who have frozen embryos and those who are keen to conceive spontaneously, maybe a little mention on those who are single. So first I will talk about those who have frozen embryo. Now, in patients who have frozen embryo, we need to do the ablation carefully to prevent involvement of the endometrium. And I usually give them GnRH analog for 3 months. And after 3 months, I advise them to do embryo transfer, whether they have menses or not. I think this is what I have been suggesting. Okay, I'll give you an example of this patient. This is a patient. She's a 35-year-old lady. She has been married for 5 years with no children. She underwent IVF in 2019 and had 2 frozen embryos. She was given 1 dose of GnRH analog, depot, which is a 3-month, and then she underwent a laparoscopy in 2020. She was given another GnRH analog monthly for 2 doses, and she had 1 embryo transferred in June 2021. Unfortunately, she did not get pregnant. Okay, she also complained, when she saw me, she complained of severe dysmenorrhea and heavy menses. She was on tranexamic acid to control the bleeding. So on examination, the uterus was 16-week size uterus. On ultrasound, there was a large posterior adenomyosis size 9.63 times 10.84 times 8.56 centimeters. Okay, this is how the uterus looks, and this is the MRI. Okay, I'll show you the other MRI as well. This is the transverse view. So the adenomyosis was more on the right side, the right posterior wall of the uterus. Okay, so she underwent HIFU on the 2nd of September 2021. This is the energy that was used. The total time was 146 minutes, and we gave 1,635 seconds. Okay, this is after 3 months. This is how the ablation looked, and this is the MRI. And this is the MRI on the transverse view after 3 months. So this is the volume reduction. Before HIFU, her volume of the whole uterus was 940 centimeter cube. And 1 month later, it was 448 centimeter cube. 3 months later, it was 318 centimeter cube. And nearly 6 months later, about 6 months later, it was 265 centimeter cube. So the volume reduction was of the whole uterus was 71.8%. So I sent her back to the IVF specialist for frozen embryo transfer. Now her IVF specialist repeated the CA125 and found that it was a bit high, 76.6. So she gave her another dose of GnRH analog, and then the CA125 reduced to 20 after 2 months. Then she did a frozen embryo transfer, and she did it without inducing any bleeding. she gave her this medicine called Proguanova, 2 milligrams 3 times a day for 11 days, and then added progesterone and did the frozen embryo transfer on the 25th of June 2022. And she was then pregnant. When I contacted her, she was 9 weeks pregnant. So this is another patient. Before HIFU, this is the uterus, is an adenomyotic uterus. And this was the ablation 1 day after HIFU treatment. And this was after 3 months of HIFU. So this patient, the difficulty of this patient, when we do HIFU in patients with frozen embryo transfer, the difficulty in this patient is to decide when is the best time to do the frozen embryo transfer. Now, I'm giving, after HIFU, I'm giving all my patient GnRH depot. This depot is actually lasts for 3 months after HIFU for my adenomyosis cases. The reason is because it is included in the patient's bill, so it is paid by the insurance. I know in China, I was told by my teacher, Dr. Huang, that it is given monthly. So in my limited experience, the shrinkage of adenomyosis after HIFU and after 3 months GnRH analog is at its maximum at around 3 months post-HIFU. So after the uterus, after that, the uterus will expand due to the weaning off effect of the GnRH analog. Spontaneous menses usually occurs maybe 4 to 6 months after the GnRH analog. So currently, I'm advising all my patients who have frozen embryo transfer to transfer the embryo 3 months after the HIFU treatment and even before the return of menstruation. So next, let's look at patients who are still single. So in this single patient, we also have to be very careful. Ablation should be done without involvement of the endometrium. And I also give them GnRH for 3 months. And then after that, patient is asked to have one of the following. They can either put in a Mirena or use Dynogest. Maybe they can go on Depo-Provera injection or on continuous oral contraceptive pills. Sometimes, okay, Implanon is okay. Okay. Now, again, this is an example of a patient, one of my patients. This was the adenomyosis before HIFU, and we did this is the ablation after HIFU treatment, and this is after 3 months. This is the volume of the uterus before HIFU treatment, which is 382, and this was 3 months after, and the volume came down to 212. Unfortunately, this patient did not come back for follow-up and only came back for follow-up much later, 10 months later. She didn't take any other treatment. And the uterine volume increased back to almost before treatment, that is 330 centimeter cube. So this tells us that in women, there is always a chance that the adenomyosis can come back. And so after the 3rd month, they should go on some kind of treatment so that the adenomyosis does not come back. Okay, next, let me look at this group of patients who are keen on spontaneous pregnancy. Now, how to give HIFU treatment for patients who want to get pregnant on their own. Again, we must be very careful not to involve the endometrium. I also give them GnRH for 3 months. And if the patient is unable to conceive, I think within 6 months, we have to consider some kind of assisted conception, such as IVF. So this is an example of a patient that I've done. This lady has a very large adenomyosis. And then we did, this is 1 day after the ablation. And this is 3 months after HIFU. And this is the volume of the uterus before HIFU, which is 396 centimeter cube. And after 3 months, the uterus volume is 178 centimeter cube, a reduction of 55%. So now I'm waiting for her to try to get pregnant on her own. If she doesn't get pregnant, I told her that she might have to consider IVF. Okay, in conclusion, adenomyosis is a very difficult problem. It is more difficult when the patient wants to conceive. Studies have shown that success rate in reducing menorrhagia and dysmenorrhea is up to 85%. Not all adenomyosis cases are the same. In some, ablation is easy, and in others, it can be difficult. In women with adenomyosis who have difficulty in conceiving, especially after failed IVF, HIFU is a good option to shrink the adenomyosis before frozen embryo transfer. There are many challenges in performing HIFU for this patient, including how much to ablate and how to avoid the endometrium. The next difficulty is to decide when is the best time to do the frozen embryo transfer. My suggestion is at 3 months post HIFU. We can also use CA125 to decide whether we can do embryo transfer or not. And this is a good option. Plan to transfer when the CA125 has reached normal value. HIFU is also can also be done in patients who have adenomyosis who want to conceive spontaneously, but she must be prepared to repeat the HIFU treatment if she did not conceive and the adenomyosis recurs. Consider IVF early in this kind of patients. Okay, thank you.